Welcome back to Audioboards. Today, we are breaking down a task you do multiple times every single shift, but is shockingly easy to mess up: intravenous fluid therapy in adults. Intravenous fluids are not just hydration, they are liquid drugs. They have specific indications, strict dosing parameters, and severe toxicities if overprescribed. Today, we are stripping away the guesswork and giving you a foolproof framework for prescribing maintenance and resuscitation fluids correctly every single time.
Let's lay down the foundational physiology first. To understand where our fluids actually go when we hang a bag, we have to remember the classic 60-40-20 rule of body water distribution. Can you break down those numbers?
Yes, total body water makes up roughly 60% of an adult's body weight. 40% of that body weight is intracellular fluid, ICF, trapped safely inside the cells. 20% of that body weight is extracellular fluid, ECF. But remember, the extracellular fluid is further split. Three-quarters of it sits in the interstitial space, bathing the tissues, and only one quarter is actually intravascular, inside the blood vessels as plasma. That distribution is critical because it explains why different fluids behave differently. If you give a hypotonic fluid like D5W, 5% dextrose in water, the dextrose is rapidly metabolized, leaving behind pure, free water. Free water distributes evenly across all compartments. Because the intracellular space is twice as big as the extracellular space, about two-thirds of that D5W goes straight inside the cells, leaving very little behind to expand the blood vessels.
Exactly.
Which means D5W is phenomenal for treating hyponatremia, but it is an absolutely useless fluid if your patient is in hypovolemic shock. For shock, you need a fluid that stays in the intravascular space, a crystalloid like 0.9% normal saline or balanced crystalloids, lactated ringers. These are isotonic to the extracellular space, meaning they don't cross the cell membrane. But remember, because of that interstitial split, only about 25% of your normal saline remains in the blood vessels. The other 75% leaks out into the interstitium.
That is why aggressive fluid over resuscitation leads so rapidly to peripheral edema, ascites, and pulmonary congestion. Now, let's operationalize this into clinical practice. The guideline breaks fluid therapy into distinct indications.
Let's tackle the first one: resuscitation. Resuscitation is for patients with true intravascular volume depletion and tissue hypoperfusion. Think septic shock, hemorrhagic shock, or severe dehydration. The goal here is immediate correction of shock. To manage this safely, modern critical care uses the ROSE framework to guide the phases of fluid resuscitation.
Walk us through those phases briefly, because knowing when to turn off the fluids is just as important as knowing when to start them.
R. Resuscitation. This happens in minutes. You give rapid fluid boluses, like 30 milliliters per kilogram, to correct life-threatening shock. O. Optimization. This takes hours. You assess fluid responsiveness using dynamic markers, like passive leg raises or stroke volume variation, rather than static pressures. S. Stabilization. This takes days. The patient is stable and you are no longer giving boluses. You are simply maintaining them. E. Evacuation, de-escalation. This is the flow phase where you actively remove fluids using diuretics if necessary to clear out interstitial edema.
Perfect. Now let's shift away from the ICU and talk about the most common fluid order written on the medical wards: maintenance fluids. This is for patients who are hemodynamically stable but cannot eat or drink, like a patient who is NPO for a bowel obstruction. What is the standard daily requirement for a healthy adult?
For routine maintenance, the rule of thumb is 25 to 30 milliliters per kilogram per day of water. Along with that water, the body needs daily electrolytes to prevent shifts: 1 millimole per kilogram per day of sodium, 1 millimole per kilogram per day of potassium, 50 to 100 grams per day of glucose to prevent starvation ketosis and minimize tissue breakdown. Let's put that into a concrete clinical prescription for an average 70 kilogram adult. 70 kilograms times 30 milliliters equals 2,100 milliliters of water per day. Divide that by 24 hours, and you get roughly 85 milliliters per hour. For electrolytes, they need about 70 millimoles of sodium and potassium. If you prescribe D521 normal saline with 20 milliequivalents of KCl running at 85 milliliters per hour, you are hitting their water, sodium, potassium, and glucose targets perfectly. But here is a massive diagnostic pitfall that trips people up. You must adjust maintenance fluids for comorbid conditions. If your patient has acute oliguric renal failure, heart failure, or severe SIADH, running maintenance fluids at 85 milliliters per hour will rapidly cause fluid overload and life-threatening hyponatremia. In those patients, less is more.
Let's finish with the major toxicities of our fluid choices. We discussed this briefly in our KDIGO review, but it bears repeating. What happens if you run liters and liters of 0.9% normal saline?
You will induce a hyperchloremic metabolic acidosis. Normal saline has a chloride concentration of 154 milliequivalents per liter, which is vastly higher than human plasma, approximately 100 milliequivalents per liter. That excess chloride drives bicarbonate out of the cells, dropping your pH and causing renal vasoconstriction. If your patient needs massive resuscitation, reach for balanced crystalloids like lactated ringers instead.
Let's hit a quick fire recap for the boards.
The 60-40-20 rule: total body water is 60% of body weight. Crystalloids stay extracellular. Only 25% remains intravascular. D5W versus saline. D5W supplies free water and goes intracellular. Great for hypernatremia, terrible for shock. Isotonic crystalloids expand the intravascular space. Resuscitation phases follow the ROSE model. De-escalate and evacuate fluids once shock has resolved. Maintenance math. Target 25 to 30 milliliters per kilogram per day of water, with 1 millimole per kilogram per day of sodium and potassium, plus 50 to 100 grams of glucose. Saline toxicity. Watch out for hyperchloremic metabolic acidosis with large volumes of 0.9% NaCl.
Great, that wraps up today's episode.
Thanks for listening to Audioboards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the Audioboards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified, board-certified healthcare provider for any medical concern.